Hello everybody, it's Dr. Kenny here. It's been a while since I've posted one of these videos. In fact, a little over 3 years, but I would like to share with you some physiology on IVC Collapse. I apologize, my audio equipment isn't as good as it was when I was a fellow, but I'm doing my best. So I recently gave a grand rounds on the physiology of volume status, volume responsiveness, how that applies to IVC collapse, and I cut out an animation slide, which I now regret because I didn't have time to finish it, but now it's here for you, um, certainly because I was inspired by Dr. Merrick's recent commentary. So the lightning bolts here represent lightning bolts of knowledge on IVC collapse and dilation physiology. So what I hope to illustrate is the following question: why does the IVC collapse? And it collapses very simply because the pressure within the IVC, the intra-abdominal IVC, falls below the pressure in the abdomen. So then the question is, well, what determines the pressure within the IVC? And this is essentially the right atrial pressure or central venous pressure, which will be abbreviated CVP. And that pressure itself is determined at the crossroads of, firstly, venous return, which has multiple determinants, secondly, cardiac function, which has multiple determinants, and third, the degree to which the intrathoracic pressure falls or raises. And then it also is determined by how the pressure outside the IVC is changing. And so the use of the IVC collapse, like any diagnostic test, will have false positives and false negatives, as indicated by specificities and sensitivities. And I think that when we look at the differing data and the debates online and the debates in the literature as to why the outcome data on inspiratory IVC collapse is varied, it just simply reflects the complicated physiology and the underlying patient population study. So with that, I'd like to bring you to the animation, which I've entitled The Animation for the Ages. It's not normal for Canadians to be so not humble. So here is the animation. Very simple, but I hope that it can illuminate some things. So this blue line here is pressure. Going up is increase in pressure, going down is a fall in pressure. And this sea level, this light green line here, dotted line, is a very important pressure, and this will be the intra-abdominal pressure. This is the right atrial pressure, the heart anterior, this is the diaphragm posterior, this is the inferior vena cava. So this is somebody sort of lying on their back and you're assessing their IVC using an ultrasound. So this waterbed looking thing represents the venous capacitance beds, and most of your blood volume lies in the veins, and so the volume of venous blood pressing out against the walls of the veins generates this elastic recoil pressure, which is very important, called the mean systemic filling pressure, and I've recently written about this on Pulm CCM. And this generates a pressure pushing blood into the heart. And then up here, this is the arterial bed. So 70% of your blood roughly is in the veins, another 20% roughly in the arteries, and then maybe another 10% or so in the capillaries. And this is a low compliance, so the walls are much stiffer than the veins, and it's a low volume arterial tree. I believe the compliance of the arteries is about 30 times less or 30 times stiffer than the veins, which is why when you eject blood into the stiff arteries, you get your mean arterial pressure, which then pushes blood back to the venous system. Round and round we go. So this venous bed is pushing blood through the IVC towards the heart. And this blue dot here is very important. This blue dot throughout the animation will represent the right atrial pressure or the central venous pressure. And it has a few conflicting forces driving it up or down. So the right atrial pressure will tend to rise relative to the intra-abdominal pressure, again the green line here, and that would tend to dilate the IVC. It tends to rise when there is an increase in venous return from the venous capacitance beds and or cardiac function is impaired. So the heart cannot eject blood as well from the thorax, so that tends to pool blood in the central veins and raise that right atrial pressure. So it could be it could be from one or the other, or a combination of the two that raises the right atrial pressure relative to the abdominal pressure. Conversely, the right atrial pressure can fall relative to the intra-abdominal pressure, and this would tend to shrink the IVC volume. And that can occur similarly as a consequence of two general concepts: a fall in venous return from the venous capacitance bed, so blood is kind of trickling in, or if cardiac function is excellent and the heart is pumping out all of the blood it's receiving. So it could be one, both, or a combination of the two. So let's talk about what happens during a spontaneous inspiration. So when you breathe in, right, intrathoracic pressure falls, and the heart will bring that right atrial pressure below the abdominal pressure here, the green line again. And when that occurs, the transmural pressure of the IVC becomes negative and it collapses. And what I've illustrated here is this tends to augment venous return, this increase in the blue arrow here, which is why you tend to bolus the heart when you breathe in. Similarly, this is also why breathing in spontaneously or decreasing the pressure within the thorax tends to increase left ventricular afterload. So it actually increases the pressure gradient from the heart to the arteries, but it improves influx of blood from the thorax, kind of like blood rolling downhill versus blood being pushed uphill. So that's a spontaneous inspiration. So let's go back to baseline. We're back to our right atrial pressure baseline. Now, what happens with a purely mechanical inspiration? So this is the patient that you've just intubated and is paralyzed, or the patient is heavily sedated and making zero inspiratory efforts. So in this situation, the pressure in the thorax rises relative to intra-abdominal pressure. You can see here, and that's going to cause IVC dilation. So in patients who are completely passive with the ventilator, and so in some of the IVC papers, particularly I believe the one by Barbier in 2004 and Feisel as well, they were looking at IVC dilation, and that was in a patient population that was essentially paralyzed, not making inspiratory efforts, and they were also receiving relatively high volumes on the ventilator, I believe 8, 10, 12 cc's per kilogram. And so that dose of volume is also going to affect how high the right atrial pressure, how high the intrathoracic pressure rises in response to a mechanical ventilation. And that would change if the volume dialed into the ventilator was less or more. So that tends to retard venous blood flow. So now the blood flow kind of has to roll up this gradient, so it's diminished. But at the same time, this is why a positive pressure breath kind of helps unload the left heart. It lowers the gradient from the left heart to the arterial tree. So let's go back to our baseline. Now, what happens during an assisted inspiration? So this is incredibly common in the ICU, but it also applies to patients who are on high flow oxygen, CPAP, BiPAP. They're receiving positive pressure, but they are also alert enough to trigger a breath. So as the breath is triggered, there'll be initially a negative deflection followed by a positive deflection. So the right atrial pressure may fall below intra-abdominal pressure and then rise above intra-abdominal pressure. So you may see IVC collapse, but it's hard to standardize this because patients will have varying effort, varying lung and chest wall compliances, varying degrees of PEEP applied. So that will complicate things. So let's go back to our baseline. And now let's talk a little bit about specificity and sensitivity. So let's call an impaired specificity of IVC collapse when the IVC collapses in a patient who will not respond to fluids. So what might bring about that situation? Well, consider a patient with septic cardiomyopathy, so their heart's not pumping forward as well, but they also have the venoplegia of sepsis, and maybe they're on some PEEP, either they're intubated or on CPAP or BiPAP or whatever, because they've got a pneumonia, say. So what this animation does here, you can see the heart getting big and the right atrial pressure rising. What that is to illustrate is this cardiomyopathy. So it doesn't necessarily mean that the heart is big and dilated and has systolic dysfunction. The heart can be impaired by a plethora of um, physiologic factors, but it's just simply to illustrate the point that the heart is not ejecting blood from the thorax as well, so that tends to raise the right atrial pressure. And as you can see, that would tend to distend the IVC because it's increasing relative to our sea-level intra-abdominal pressure here. But say also this patient's sepsis is evolving and they're becoming venoplegic, also vasoplegic, but also venoplegic. And what that does is it tends to kind of increase the capacitance of the venous beds. So their volume, blood volume may stay the same, but because the venous beds are kind of becoming big and floppy, that elastic recoil pressure or the mean systemic filling pressure falls. And that tends to lower inflow and therefore lower the right atrial pressure. So you've got this heart, this kind of crummy heart that's not pumping blood out so well, but at the same time you've got this venoplegic physiology where heart is not, or sorry, where blood is not coming into the right atrium as well. So the right atrial pressure may not change so much. Now here's the kicker. As I said, the patient is also on PEEP for whatever reason. And what is often forgotten and is nicely illustrated in a number of trials. It was initially postulated decades ago and then kind of shown in a classic paper by Henry Fessler in the early 90s in Saul Permit's lab at Hopkins, and then again in a paper by Yule Olson in healthy volunteers, that when you apply PEEP to the thorax, you also pressurize the upper abdomen. And so what that does, what the PEEP does, is it raises your intra-abdominal pressure. So see, the green line is rising. And so what that is going to do is you can see if you're raising the pressure around the IVC, it's going to make it more likely that it will collapse, even though this patient is not going to respond to a fluid challenge. What you have here now is a situation where the IVC appears small and diminutive as a consequence of low venous return and a high intra-abdominal pressure. So now when this patient breathes in, it will just continue to collapse. And then if that patient takes a really negative inspiratory pressure, it will collapse all the more. But as I said, this patient will not respond to fluids. So this will impair your specificity. It will give you a false positive. You'll see the IVC collapse. You'll say, oh, hey, this patient will respond to fluids. I'm going to give them a challenge, but they actually won't. So clinical states where you need to look out for, where you will see IVC collapse in a fluid non-responsive heart, as I've illustrated, low venous return. And that could be from a lot of reasons. If somebody's hemorrhaging badly, if they've got venoplegia, if they have adrenal insufficiency, all of these things will lower the mean systemic filling pressure and lower the pressure of blood entering the IVC. Importantly, when there's increased intra-abdominal pressure and or the application of PEEP. So another good situation might be the cirrhotic, right? Cirrhotics are venoplegic, and then they may have ascites and intra-abdominal hypertension, which would tend to collapse the IVC. Obesity would also do it, any cause of intra-abdominal hypertension. And then also, as I've illustrated, excessive inspiratory efforts. If you breathe in very deeply, you can force that IVC to collapse, even if your right atrial pressure is high and the heart is on the flat portion of the Starling curve. So let's go back to our baseline, right atrial pressure, and now let's consider the converse, an impaired sensitivity of the IVC. So this is when the IVC collapses minimally or does not collapse in a patient who will respond to fluid. So this is the patient, you look at the IVC, it looks relatively dilated or engorged, and you think, oh, I'm going to stop. But in actuality, that patient would respond to a subsequent fluid challenge. So it's somewhat the converse of the previous one. So consider a volume-loaded patient. You've given them 4 or 5 liters of crystalloid for probably not a great reason, but they've received it. They're breathing without assistance, and maybe they're on some epinephrine because you like that pressor. So now the mean systemic filling pressure is high because of all the volume you give them, and also because the alpha effects of epinephrine will cause the venous beds to clamp down, and now you're going to have a high pressure head pushing blood back into the thorax, which will tend to raise the right atrial pressure. And let's say that cardiac function is okay. Maybe the patient's got some diastolic dysfunction, maybe they flipped into AFib, maybe they kind of had a septic cardiomyopathy, but the beta effects of the epinephrine is actually keeping cardiac function relatively reasonable. So that right atrial pressure maybe falls a little because of good, decent cardiac function, but not a lot. And then say this patient doesn't take a terribly deep breath in at the same time. Well, now you're going to see the heart and the right atrial pressure fall, but it might not quite get to the intra-abdominal pressure, even though the venous return curve is still intersecting an ascending portion of the cardiac function curve. You may breathe in, and it won't quite get below that intra-abdominal pressure, and you won't see IVC collapse, or you'll see just a little bit of collapse. Another possibility, and this was shown in a paper by Kimura, I believe, where you can actually breathe differently if you breathe diaphragmatically versus if you breathe with your chest wall. If you breathe with your chest wall, you won't have as much IVC collapse because the intra-abdominal pressure is probably not changing to the same degree. So clinical states which favor minimal IVC collapse, but in a patient who's fluid responsive, could be seen in a state of high venous return, as we've seen, if there's decreased abdominal pressure, or the patient is using accessory muscles to breathe rather than diaphragmatic muscles, or in patients with less vigorous inspiratory efforts. So that was it. That was the animation for the ages. I hope that it was revealing. And the following words I have to say is, it's not like you're pro or a con IVC collapse. I think it's just important to understand the nuances, the difference between collapse and dilation, the difference between purely spontaneous breathing, purely mechanical breathing, and assisted breathing, and how that will change IVC collapse, and the co-varying contributions of venous return, cardiac function, intrathoracic pressure, and intra-abdominal pressure. What I left out of the animation is that every time you take a breath in, your intra-abdominal pressure tends to rise a little bit, but for simplicity, I left that out. One thing that I would like to say is that the collapse of the IVC is not a dynamic marker of the cardiovascular system as sometimes is indicated. It's just a non-invasive visual transduction of the central venous pressure. And that's been written about before by people much smarter than me, but if you can kind of look back at the data and you think about it a little bit, there's the Muller trial in 2012 that people talk about. It had a specificity of 80%, which means that there was 20% false positives. And in the Coral trial in 2017, which Scott just posted on, there was also a specificity of 80%, or a 20% false positive rate. And then if you look back at some CVP data by Magder, a decade ago, what he found was that a CVP of 0 to 5 millimeters of mercury, which would be a low distending pressure, and therefore you'd expect to see IVC collapse, also had a specificity of 75% for predicting fluid responsiveness. So the data is actually surprisingly consistent in these groups of patients, which were of varying populations, but some were in the ICU, some were in the ED, some were receiving mechanical ventilation, some weren't. So it's not entirely disparate here, and it tends to corroborate the idea that the IVC collapse is a surrogate of the CVP. So what I think is that the patient population studied will alter the results in predicting fluid responsiveness from IVC collapse. And if you consider two very different populations, it would be very different if you're comparing only hospitalized elderly cirrhotics on mechanical ventilation to young, healthy trauma patients in the ED. IVC collapse for predicting fluid responsiveness in those two different patient populations would be extremely different based on the physiology. And I think the difference lies in understanding, as I mentioned, the intersection of venous return, the blood being pushed into the IVC from the venous capacitance beds, cardiac function, ejecting blood from the heart, while appreciating the superimposed effects of intrathoracic and intra-abdominal pressure. For more details, please check out heart-lung.org, particularly chapters 2, 6, but most pertinently chapter 8. And I put up some physiology modules that I think will help illustrate this physiology. The final thing I'd like to say is from a Gattinoni paper on physiology-based medicine. It's literally the last sentence of the paper. Physiology helps to design premises and theories. Without strong premises and theories, whatever the trial will prove is, in the best case, useless, or if misinterpreted, dangerous. You've got to understand the physiology first before designing these trials, and certainly when interpreting these trials. Here is the references, which I will also put in a brief blurb. Thank you so much for your time. Thank you for watching. See y'all later.